Okay, is my voice clear? Clear, right? Fantastic. So we finished the anatomy for part A. Now we're gonna continue, and today we're gonna start with the physiology. So from classroom, you press on physiology, and that's our physiology part. Okay. We updated the calendar for you guys here. There's different lectures, and it's gonna be me and Mr. Minallah. Okay. For today, we're gonna start with electrolytes and alkalosis, and then we're fluid and acid base balance, and then electrolytes, and this will be the session for today. It's not gonna be a hopefully it's gonna be an easy one. Okay, and not that long. Recording is started. Okay, so for the physiology part, we're gonna start with acidosis and alkalosis. So acidosis and alkalosis is very important for you to understand for your life, not just for your exam. Okay, very crucial, very important to understand it for life, not just the exam. You will definitely need to analyze acid base balance. Definitely through your career, you will need to analyze acid base balance. Okay. All right. So this in the exam they will give you these numbers. However, if you memorize them, that will be better for you. Will make it easier for your exam. So the normal ABG values, because why I want you to memorize this one and put it try to keep it in your head, because this will help you identify is your patient on acidosis or alkalosis. And for a bigger picture, why acidosis and alkalosis is very crucial and very important, because your body function needs a specific pH to function. All the enzymes, all the hormones, all your body functions depend on a specific environment. Thus, acidosis or alkalosis is very harmful. You could die from them. That's why we need to keep the environment of the body within specific numbers. Okay, so that's the importance of acidosis and alkalosis, and why we make such a fuss about them, because they are crucial and they are very important for life and also for your MRCS exam. Okay, both of them. All right. So these values, you're going to use them to identify the pathology of your patient. So you need to keep an eye on them. Okay. So you have normal ABG values. pH is between 7.35 to 7.45. If it's less than 7.35, that's acidosis. If it's more than 7.45, that's alkalosis. BCO2, which mean the saturation of not saturation, the accumulation of CO2 is between 5 to 6 kPa. Reflect the respiratory component. HCO3 is the bicarbonate. The normal value is 22 to 28. If it's less than 22, that's acidosis. If it's more than 22, 28, that's alkalosis. However, it does reflect the metabolic component. All right. Base excess mean increase of HCO3, the gas metabolic alkalosis. So if you have HCO3 more than 0.2, base excess more than +2, that's a gas alkalosis. Okay, base excess less than -2, that's mean decrease in HCO3, the gas metabolic acidosis. All right, very important for your MRCS exam, very crucial. All right, simple rule. Acidosis, that means pH is low. pH is low, lower than 7.35. Alkalosis means pH is above normal, meaning pH is above 7.45. BCO2 problem, usually respiratory problem. HCO3 problem, usually metabolic problem. Okay, and how you know the normal references is here. This is how you know the normal references for each one. Okay, all right. Acid base disorder. Now this time this table will just summarize everything for you. However, we will come into details for each one. Okay, let me just
Shaza,
see.
Shaza, did you open your camera or by mistake? Because your camera is on.
I don't see camera open.
It was open.
Okay, let's see if she was able to get into. Oh, Mariam, I tagged you to the video. I tagged her to the video here. Did Mariam join yet or not yet? Still not joining. I tagged her on the group because I wanted to avoid such an event. Sorry, guys, just 1 second. Okay, let's continue. So this is the general rules of acidosis and acid-base balance. Okay, so you have either respiratory acidosis or respiratory alkalosis, and you have either metabolic acidosis or metabolic alkalosis. Okay, each one of these could be compensated, meaning the body will act to correct them. That's what we mean by compensation. Your body will act to compensate them. I hope that's clear. If you have respiratory acidosis, your body will try to compensate by creating metabolic alkalosis because you have respiratory acidosis already. How your body will compensate for respiratory acidosis by trying to increase the bicarbonate. Because if you remember here, we said HCO₃ problem is a metabolic problem. The bicarbonate problem is metabolic problem. If the bicarbonate goes up, that metabolic alkalosis. If it goes down, that metabolic acidosis. And if you have respiratory alkalosis, your body will try to compensate by creating metabolic acidosis, meaning your body will try to get rid of the bicarbonate to make your body acidotic. So the main idea, we want to keep the environment of the body, interstitial fluid and the cells between 7.35 to 7.45, making it within normal range. Okay. All right. Here are common causes for each one. However, we're going to speak about this in detail. We're going to speak about this in detail. We're going to speak about this in detail. We're going to speak about this in details. If you can see here, if you have respiratory acidosis, usually your body will be CO2 will increase in the body due to hypoventilation, reduce in your breath, or respiratory center, decrease in respiratory center activity. For example, if your patient is taking morphine, or if your patient is retaining by COPD. These are the common causes of respiratory acidosis. If you notice, all of them will increase the CO2 in the body. How? Because there is no excretion of the CO2. You breathe oxygen, you excrete CO2. Okay? You breathe oxygen, you excrete CO2. All right? Just 1 second. Sorry, guys. Okay, let's continue. So these are the most common causes of respiratory acidosis. Here in the ABG, you will find your patient has low pH and has increasing BCO2. Okay? If it's uncompensated, the HCO3 will be normal, meaning your body didn't try to correct the respiratory acidosis. How your body will try to correct the respiratory acidosis? By creating more bicarbonate. And we all know bicarbonate is alkaline, right? Alkalytic. So if it's uncompensated, the HCO3, the bicarbonate will be normal. If it's partially compensated, the HCO3 will be increased. And how you know the normal value is here. I wrote it already for you, between 22 to 28. Tell me, give me thumb up if this column is clear, because it's going to get more complicated. We need to understand why one by one. Okay? So, Shaza is not clear. Rania, Rahiq, fine. All right. Second one, respiratory alkalosis. The CO2 is decreased in the body. What will lead to the decrease in CO2 in the body? One thing. One thing might lead to decrease in the body, which is decreasing the CO2 in the body by hyperventilation. If you're doing this, you are excreting CO2. All right? When you excrete CO2 outside, I want you to think about CO2 as acid. And I want you to think for bicarbonate as alkaline. So when you excrete CO2, you will lead to respiratory alkalosis. Why? Because you took the acid outside your body. When you take the acid outside, that means it's alkaline now. Okay? By hyperventilation, if for example someone has panic attack, very important for your exam, MRCS Part A, panic attack, that's lead to respiratory alkalosis. Respiratory center by hypoxia or hypotension. If you stimulated the respiratory center, or for example, if the patient has pulmonary embolism, because the patient with pulmonary embolism will be hyperventilating, will be tachypneic and tachycardic. Okay? If it's uncompensated, the HCO3 will be normal. If it's partially compensated, the HCO3 will be on the lower side. Why? Because you have alkalosis, right? So your body will try the best to get the bicarbonate outside in the urine, because the bicarbonate is alkaline and your body is already alkaline, so your body will push the bicarbonate outside. Okay? All right. This is the respiratory acidosis and alkalosis. Metabolic acidosis. Metabolic acidosis increasing the H plus or decreasing in the HCO3. As I said, I want you to think about CO2 as acid. All right. So decreasing HCO3 is metabolic acidosis. Causes diarrhea as high output fistula. And I will tell you exactly why diarrhea causes metabolic acidosis. Addison, peritonitis. Why? Because peritonitis may lead to increase in the lactic acid. Lactoses is acidic. So this will lead to metabolic acidosis. DKA, diabetic ketoacidosis, the name says it all. And also increasing saline intake. Increasing saline intake. I will tell you why when you give your patient a lot of saline, why he will become metabolic acidosis when we come down there. Okay? All right. The ABG, arterial blood gas, this ABG means arterial blood gas, will show decrease in pH and decrease in HCO3. Decrease in pH, we said that's acidosis, right? There will be decrease in HCO3. How will you differentiate it from the respiratory? The BCO2 will be normal. Okay? If it's uncompensated. If it started to be compensated, your body will try to get the CO2 outside. Why? Because your body is acidotic, so it will try to push the acid outside. How? It will push the CO2 outside. All right. Tell me if this column is clear, because if you didn't understand this one, it's going to get more complicated. We have to understand all of this. Okay, fantastic. All right, metabolic alkalosis. This is due to decrease Hc plus or increase HCO3. CO3 we said bicarbonate. So when it increases, it will increase the alkaline. And this will lead to metabolic alkalosis. Causes vomiting, cons or Cushing, NG tube. We'll tell you the pathophysiology in a second. ABG button, there will be increase in pH. We already said what does alkalosis mean, increasing pH. The HCO3 will increase. That's why the name is metabolic alkalosis. If it's uncompensated, the PaCO₂ will be normal. If it's compensated, the PaCO₂ will be increased. Why? Because your body is alkalotic. Your body will try to withhold the CO2. How the body will withhold the PaCO₂? By reducing your ventilation. When your body reducing your ventilation, you will keep CO2 inside your body to try to compensate for the metabolic alkalosis. If you have a juice, let's say you have a juice, okay, or drink, and you added water to the drink, you can add sugar to make it balanced. لو عندك مويه وضفت له عصير وكبت له مويه هيبقى مسيخ. عشان تصلحه بتكب له سكر. نفس الفكره. The body is trying to balance between the acidosis and the alkalosis. This table is very crucial, and this table alone should be able to make you pass your exam. All right. Now we're going to tackle each one in details. Respiratory alkalosis, decrease in CO2 in the body. Common cause, hyperventilation, increased respiratory center by hypoxia or hypotension and pulmonary embolism. We already showed you the ABG. If it's uncompensated or partially compensated, we showed you in the image. All right. Respiratory, same. Respiratory alkalosis, decrease in PaCO2, hyperventilation. PaCO2 will be less than 4.5 kBA. And I showed you here the normal range of PaCO2, 4.5 to 6. So if it's less than 4.5, that means it's slow. Okay. That's why I put this in the top of the big on the table, so you can memorize that one. Okay. Let me make sure this is recorded. Okay. All right. So causes of respiratory alkalosis: anxiety, panic attack. I just told you that. Very high yield for your exam. Pain. Why? Because when you have pain, you will be tachypneic. Fever and sepsis, because also you will be tachypneic due to hypotension. Pregnancy, you will be tachypneic. High altitude, you will be tachypneic. So if you want to think about all of these, think about hyperventilation. Hepatic failure in early stage. Salicylate poisoning, very important in early stage. So in early stage, if your patient talks salicylate, what is salicylate? What is that medication? What do we mean by salicylate? Sorry?
Aspirin.
Aspirin, yes. Aspirin. Very important, very high yield, very crucial, okay? This one and the panic attack. Hypoxemia, like anemia or hypoxia, because you will be tachypneic, obviously. Iatrogenic mechanical ventilation, because this will lead to hyperventilation. Hyperthyroidism and CNS disorder, like meningitis, encephalitis, and head injury. All of these are important. However, I want you to remember this. I want you to understand all of this. Remember A, or understand from A to 5. Anxiety will lead to hyperventilation. Pain will lead to hyperventilation. Fever will lead to hyperventilation. Hepatic failure doesn't lead to hyperventilation. However, this one, 9, will lead to hyperventilation. So 6 or 7 of them you can just remember by hyperventilation. If you can see here, anything that cause increase in ventilation lead to decrease in PaCO2, this will lead to respiratory alkalosis. All right. Associated condition causing hypokapnia. So you have, with respiratory alkalosis, you have normal PaCO₂, which is this one that we mentioned, or you have high PaCO₂. So your patient trying to compensate in a way, okay? So for this one, I just want you to remember pain and anxiety and forget about this table. I'm going to take it off, okay? Forget about this table. It will just confuse you. I don't want to make it confusing. If you are working ICU, that's fine, but just remember this table for me. This one, the one on the right. I will take this off. I will cross it off. All right. So this, the respiratory alkalosis in detail. Now, metabolic alkalosis. We already showed you the pathophysiology in the table I just mentioned earlier. Vomiting, cons, NG tube. ABG button, I already showed you the pH will be high and the HCO₃ will be high. Uncompensated PaCO₂ normal, partially compensated PaCO₂ will be high. Okay? All right. Metabolic alkalosis. HCO₃ will be high. Loss of H plus or gain of HCO₃, meaning in order for you to get metabolic alkalosis, the HCO₃, either you lose H plus, meaning lose acid, thus you will be acidotic, or gain HCO₃. The HCO₃ will be more than 26 or 28. We said the normal variant 22 to 28. All right, what are the causes? Vomiting will lead to loss of gastric HCl. So gastric HCl, meaning you will lose the H plus. As you can see here, we said it's loss of H plus, meaning loss of the acid. So when you vomit, you will lose HCl. That's acid. You lose H plus. That will lead to metabolic alkalosis. Okay? Nasogastric suction, same idea. When you vomit or when you do nasogastric suction, same idea. You will suck the blood from inside. Diuretics use like lube or thiazide. If someone answered for me, I will give him a gift. Diuretic use, why does it cause metabolic alkalosis? Loop diuretic, why does it cause metabolic alkalosis?
قصدي انه بيحصل سكريشن ل اتش بلس وبيتعمل
سكريشن لشنو؟ بيحصل سكريشن لشنو؟
للهيدرو اتش بلس وبتدخل البوتاسيوم.
ايوه الله يفتح عليك. الموضوع كله بالانس بالبوتاسيوم. الاتش بلس خلاص تمام 100 عندك هديه يا صفوت. عندك هديه عطر كبير اول ما اجي السعوديه ان شاء الله. نوريك هديتك كده. دي الهديه بتاعتك.
دي هديه بابكر. الجواب بابكر.
دي هديتك شايفه؟ هاني عود. اوكي عشان نوفي بوعدنا بعد نجي السعوديه ونسلمك. هاي دي بابكر تمام. اوكي يلا اوكي يس الموضوع كله the idea is the potassium. All right. So when you lose when you give your patient one of these diuretics, your patient will lose potassium. This will lead to hypokalaemia. When it does lead to hypokalaemia, the body will try to compensate for the hypokalaemia because the body lost K plus. So the body will try to retain H plus. When the body retains H plus, this will lead to acidosis. Or the body will try to compensate for the metabolic alkalosis by creating metabolic acidosis, retaining the H plus. Give me thumb up if you understand. If you don't understand, open the mic and tell me you didn't understand. Fine. So
again, please, Doctor.
Okay, let me repeat it for you.
Please,
So,
yes.
so this Diuretics will make you lose the potassium in the renal tubule. We're going to come to it when we speak about the renal physiology. Okay? You will lose potassium. That's why spironolactone, we call it potassium sparing diuretics. So spironolactone, we call it potassium sparing diuretics. Why? Because the spironolactone reserve the potassium. Okay? However, the loop diuretic like furosemide and the thiazide diuretic like hydrochlorothiazide, they don't preserve the potassium. They lose the potassium. So you will lose the potassium in the urine. So when you give someone furosemide and thiazide, be cautious that you don't take your patient to hypokalaemia, because your patient will lose the potassium. Okay? Okay. When your body loses the potassium, you lose K plus. Potassium is K plus, right? Okay, Adil, are you following? Okay, when you lose K plus, because your body, the electrolyte should be balanced. If you lose K plus, you either lose K plus, you either lose a negative, what do they call it? You either lose plus or you gain plus. You lost plus, right? So you either gain minus or lose plus. Just in simple words. So the electrolytes in your body should be in a natural position, equal, positive and negative. If you think about your body, is a massive laboratory. You have electrolyte and you have chemical reaction every second. So when you lose the K plus, because this diuretic will make you lose the K plus, the potassium, your body will try to compensate by gaining the H plus. So the renal tubules will absorb the H plus more than it's used to. And this will lead to the body trying to compensate. I hope it's clear now. Adil.
Yes, it's clear. Yeah.
Very complicated though. You need to go and read about it. Yes. Then also mineralocorticoids. Mineralocorticoids will lead to Cone syndrome and Cushing syndrome. We'll come to this in the endocrine. However, the idea of this is increasing in the aldosterone, okay? And the aldosterone will make you absorb 2 sodium and lose 1 potassium. Okay? So the same idea of the diuretics here is the mineralocorticoids here. The cause is the hypokalaemia. So basically this one, and this one, 3, 4, and 5, basically the same thing. Diuretics will lead to hypokalemia. Mineralocorticoid will lead to hypokalemia. And hypokalemia is hypokalemia. When your body has hypokalemia, meaning your body lost a lot of K plus, so your body will absorb the H plus. Try to compensate. Okay? And then the last 3 are not that important. And if you think about laxative abuse, is exactly the same as vomiting. Instead of you losing the fluid from upstairs, you're losing it from downstairs. That's it. Okay? Bartter syndrome, if you ask me now what is Bartter syndrome, I don't remember. I need to remind myself what is Bartter syndrome. Okay. Thick ascending limb, loop diuretic, and the defect. Okay. That means there is a defect that will act like diuretics. Okay. That not high yield. Don't worry about it. Don't memorize this one. Just focus on the top. And also like the same one, I'm going to change both of these tables. I'm going to take this side of the table is our side. This is more than important. Okay. Respiratory acidosis happens when the body cannot remove enough carbon dioxide through the lungs. CO2 builds in the blood. Blood becomes more acidic. pH goes down. pH goes down. I told you think about CO2 as acid. Okay? All right. Pathophysiology. Decreased breathing will lead to CO2 retention. Carbonic acid in the blood. This will reduce the pH, meaning it will be acidotic. Simple equation: CO2 plus H2O will lead to HCO3 plus H plus. This table, this equation can go this way or can go this way. More CO2 mean more acid, as I already said to you. Common causes: lung disease like COPD, severe asthma and pneumonia, brain problem like head injury, drug overdose like opioids. Always think of opioid as a drug that reduce your ventilation. Muscle weakness, myasthenia gravis and Guillain-Barré syndrome. Why? Why this may lead to respiratory acidosis? Why? Why myasthenia gravis and Guillain-Barré will lead to acidosis? Why?
لانه بتعمل ويكنس في الريسبيراتوري muscle.
Yes. If you can speak in English, that will be better, Safwan.
Okay.
Yes, fantastic. Fantastic. That's the answer we want. Guillain-Barré and myasthenia gravis. What is the pathophysiology of myasthenia gravis? Without you opening the internet. What is the pathophysiology of myasthenia gravis? Babikar, I can't hear you.
Effect on acetylcholine receptor.
Sorry? Babikar, can you speak?
Effect on acetylcholine receptor.
Fantastic. Yes. Defect in acetylcholine receptors. When you have acetylcholine receptors defected, that means the acetylcholine will not be able to bind with the neuromuscular junction, and then you will develop the weakness. And how do we treat it? By giving acetylcholinesterase. So it's not the acetylcholine receptor. There's antibody against the acetylcholine receptor. There's antibodies against the acetylcholine receptor. Yes, 100%. Yes. Not receptor. There's antibodies against the acetylcholine receptor. You treat it by giving acetylcholinesterase inhibitor, like neostigmine and physiostigmine. So you give a drug that prevent the acetylcholine from breaking down. This will increase the acetylcholine receptor in the receptor, and then you will have the effect. I will explain this to you when we come to it. The idea here, myasthenia gravis and Guillain-Barré syndrome, both of them lead to respiratory depression by affecting the respiratory muscle. You will not be able to breathe much. Chest problem, severe obesity, you won't be able to breathe much. Rib fracture, you won't be able to breathe much. Pneumothorax, you won't be able to breathe much. I already showed you the ABG for it. You can go to the table on top. All right, respiratory acidosis causes due to poor ventilation of the lung. All right. Respiratory depression for like drunk, anesthesia, sleep, or brain stem lesion. Airway obstruction like asthma, COPD, emphysema, and bronchospasm. Muscle problem, Guillain-Barré syndrome, and we said myasthenia gravis. Heavy chest wall disorder like kyphoscoliosis, obesity, hypoventilation. Disease of the lung parenchyma and airway neuromuscular problem like myasthenia gravis, motor neuron disease, and phrenic nerve palsy. Okay. All right. This is the metabolic acidosis. This is the pathophysiology. There will be acid production increase or loss of bicarbonate. The lung try to compensate by breathing faster to remove CO2. Very clear. And this is the common causes of metabolic acidosis: diabetic ketoacidosis, lactic acidosis, and renal failure. Severe diarrhea, intestinal fistula. Poisoning like methanol, ethylene glycol, and salicylate. ABG button. If it's uncompensated, the pH will be low because of acidosis. HCO3 will be low because the body didn't compensate by increasing the HCO3, which is bicarbonate, which is alkaline. PaCO₂ will be normal. If it's compensated, PaCO₂ will be low. Why? Because the body is trying to compensate for the acidosis by trying to push more acid outside. Okay. Okay. Metabolic acidosis. This is the image. All right. Kussmaul breathing, for whatever reason they like to ask about it. The patient breathes deep, fast, and heavy. This is the body trying to remove CO2 and reduce acidity, common in DKA and severe metabolic acidosis. So they may present a scenario for you, throw a scenario for you. Your patient presented with and he has diabetic ketoacidosis, abdominal pain. Abdominal pain could be a presentation of diabetic ketoacidosis, and they tell you the patient is breathing heavily. What do we call this breathing? It's Kussmaul breathing. So from this lecture, I want you to know that panic attack and pain will lead to respiratory alkalosis. All right? And I want you to know that salicylic acid will lead to, in early stage, will lead to what? Open the mic and tell me. We said respiratory alkalosis. All right? This is the most important point and is high likely to appear on your exam. Okay? I don't want the lecture to be long. So this is the acidosis and alkalosis. I hope you have a big idea. This will help you in your life, not just the exam. Yeah, membership is pending. Let's approve it. Okay. Someone asked how to join now. All right. Now we're going to tackle the electrolyte. Unfortunately, this is also not easy. However, we'll try to be efficient. Just mention the high yields and then move on. We're going to speak about the potassium and the related disorder with the potassium, then the calcium, then the magnesium and chloride, and then the siyada. Okay. Let me just take this. Why I'm not able to deal with that's strange, man. Okay. All right, so let's start with the potassium. The daily requirement of potassium, 0.5 to 1 milliequivalent per kilogram. If patient is 70 kilograms, so their requirement is 70 milli equivalent per liter or per kilogram. Okay, so if I ask you now, can you give me a reference? Like from which, so if the patient is 70 kilogram, that means he should take 35 to 70 MEQ per kilogram. Okay. Hypokalaemia is serum potassium less than 3.5 millimole per liter. That's the definition of hypokalaemia. Causes: diarrhea, vomiting, high output fistula, NG tube, villus adenoma or rectal adenoma. Why? Because colon and rectal. Yes, Mustafa?
Write it 35 to 70. Just write 35.
Why? It's very clear, man.
Yeah, I don't know why.
Okay, fine. 35 to 70, fine. Because you have 0.5 to 1 milli equivalent, okay? All right. Renal causes: diuretics, hyperaldosteronism, which call it Conn syndrome. We'll speak about this in the endocrine when we come to the endocrine. Cushing syndrome and renal tubular disorder. All right. Intracellular shift. What do we mean by intracellular shift? The specific occasions or the specific medications that will lead the potassium to get inside your cells. Okay? One of them, if you give your patient insulin, potassium will go inside the cell. Beta-2 agonist. That's why we use the insulin and the B2 agonist at the treatment of hyperkalemia. Why? Because both of them take the potassium from the interstitial fluid or from the plasma, shove it inside the cell. Okay? Do you understand? Mustafa, do you understand? All right. Fantastic. So the idea is the intracellular shift, insulin and beta-2 agonist. And I'm going to give you a clinical point here. I want you to take and to put it in your mind. If you have patient, let's say you are working in the hospital tomorrow, okay? And you have a patient who had a potassium of 3.5 or 3.4, let's say. He has hypokalemia, textbook hypokalemia. You started to give him Sanduke, which is a supplement to increase his potassium. And his potassium became 3.6 the next day or the day after. Should you stop the Sanduke or should you continue?
Stop it.
Okay. Anyone has the opposite idea or disagree with Safwat? Yes, from the intravascular space to the intracellular space. Anyone disagree? So you shouldn't stop it, ya Safwat. You should continue giving the potassium for another 1 or 2 days. Why? Because the result you saw is not the accurate result because you have potassium outside, okay, intravascular or in the interstitium. This will need to go inside. This will continue going to the cell. So it's 3.6 now. If you stop the potassium now, you will measure it tomorrow. It will be 3.3 or 3.4. Okay. So because of the intracellular shift, you should continue the potassium a bit more than the correction. Okay. You understand يا صفوت؟ دي نقطة تمشي تشرشح بيها بعدين إن شاء الله وأنت شغال الهاوس مان. البوتاسيوم the potassium corrected, we shouldn't stop it directly. Why? Because the intracellular shift. Mustafa, you want to say something?
Repeat it, please. I don't know if I'm the only one who didn't understand.
Look, your patient potassium is 3.4, right? You gave him Sanduke, which is literally supplement of vitamin K. Your patient, you measure the potassium tomorrow, you found the 3.6. 3.6 is not hypokalemia, right? Hypokalemia, we said any number below 3.5. Should you stop or continue the Sanduke, which is literally potassium?
You said stop.
No, I didn't say stop.
Sorry. Continue.
Safwat said stop. I said you should continue for another or 2 days. Why? Because the result you see is not accurate. The potassium is still intracellularly. However, some of it will go inside the cell. So it's 3.6 now. If you measure it tomorrow, it will be 3.4. So you continue for more, putting in mind the intracellular shift. Okay?
So if I came after 2 days and find it 3.6, should I stop it?
No, you continue till you reach a number that's, let's say, 4.4 or 4.3, just to make sure the intracellular shift will not get you back to the hypokalemia. Do you understand?
No.
Oh, Mustafa, let me explain again then. Let me bring my hand. I wish if I can show something from here. Look, let me bring a paper. Let's see if I can take this and show you the video. Because if you didn't understand it, I'm not gonna move from it. Let me see. Okay. Do you see, Mustafa, this? Do you see this?
Yes.
Okay. This is potassium running. Okay. This is a
The
cell.
blood.
This is a cell. Yeah. This is the interstitial fluid here. It has also potassium. Okay. Are you following?
Yes.
All right. You took a sample of blood. Potassium is 3.4. Okay.
Okay.
You gave your patient potassium to correct this one because 3.4 is hypokalaemia. You want it to be 3.5 till 4.5, right?
Okay.
All right. The potassium here is 3.4. You gave your patient potassium for 1 day. You came tomorrow, you took another sample. You found the 3.6. Okay?
Okay.
Do you see that? Yes, you found the 3.6. Should you stop the potassium or continue? You're giving the tablet, you're giving Sanduke.
Continue.
Why? Because the result you see here is not accurate. You know why? The potassium is 3.6, right? Which is not
Yes.
hypokalemia. However, these cells are thirsty for potassium. They will suck potassium inside. Do you understand?
Yes.
So when they suck the potassium inside, when you come to measure it tomorrow, you won't find the 3.6. You will find the 3.4. So you need to give potassium till you reach, for example, 4.2 or 4.4. I don't have a specific guideline for which number you should stop. However, if it's 4.4 and you stop the medication and you came, these cells are thirsty to take the potassium. It won't suck the potassium till it reaches 3.5. It will be above 3.5. And that means you solve the issue of hypokalemia. Okay?
Okay. Thank you. Thank you.
Let's move to the next. All right. Other causes are low intake, like malnutrition and refeeding syndrome. Refeeding syndrome meaning if someone is malnourished for a long time, anorexia nervosa or whatever, and they start to eat, the body will absorb the electrolyte, and the patient will have refeeding syndrome. In refeeding syndrome, your patient will have hypokalemia, hypophosphatemia, and everything. Yes, if you're giving insulin, the insulin will shove the intracellular potassium to the inside. Just put that in your mind. All right, clinical picture. If you have hypo or hyperkalemia, if you have hypokalemia specifically, the one that we mentioned here, this may lead to arrhythmia, paralytic ileus, constipation, or muscle weakness, cramps, and reduced reflexes. ECG changes for hypokalemia, flat T wave, ST depression, prominent T wave, long BR interval, and long QT interval. All of this, I put them here. This nice image for you. Okay. So as you can see, all the images, we put our signature on it. So this is a normokalemia, meaning normal potassium. Here you have the hypokalemia, slightly big B wave, ST depression, shallow T wave, and prominent U wave. Here the hyperkalemia, which we'll come to it in a second. Prolonged PR, widened QR, depressed ST, and tall peak T wave. If you ask me what I should remember, I will say remember one thing. If you have hyperkalemia, your patient will have tall peak T wave. tall peak T wave. Okay, this is what will come to your exam. All right, severity of hypokalemia: mild 3 to 3.5, moderate 2.5 to 3, severe less than 2.5. So from normal to be mild, you need to reduce by 0.5. From mild to become moderate, you need to reduce by 0.5. And from moderate to severe, you need to reduce by 0.5. Management of hypokalemia. Look, if it's mild 3 to 3.5, you can give oral potassium. We call it Sandocaine. Okay? Potassium chloride tablets or oral solution. Typical dose 20 to 40 millimole per day in divided doses. No need to give IV usually. Okay? Treat the underlying cause. This is very important. And also correct the magnesium. So clinically, while you're working in the hospital, think about correcting the magnesium. It's not just the potassium. If you corrected the potassium without correcting the magnesium, you will never reach a normal degree of potassium. Moderate 2.5 to 3 oral potassium replacement, still potassium chloride tablet oral solution, typical dose 40 to 60 is higher dose. Give IV replacement if the patient is unable to take orally, severe symptoms, or if there's any ECG changes. Treat the underlying cause. Correct the magnesium deficiency if present. If it's severe, less than 2.5, IV potassium replacement. Cardiac monitoring required, meaning you're going to take your patient to specialized area, ITU, ICU, or whatever. Oral replacement may be used if IV not possible and patient is asymptomatic and able to take orally. However, IV potassium replacement is the way to go. IV potassium dilute in IV fluid, 40 millimole, for example, in 500 millimole. Peripheral line, it shouldn't be more than 10 millimole per hour. This is very important. So when you give the potassium, you don't overcorrect it. The maximum you can give is 10 millimole per hour. So if it's 40 millimole, the minimum or the maximum you can give this 40 millimole is in 4 hours. You shouldn't give more than 10 millimole per hour. Okay? I hope that's clear. All right. We finished the hypokalemia. Hyperkalemia definition: serum potassium 5.5 millimole per liter. It could be due to ACE inhibitor, potassium sparing diuretics like spironolactone, beta blockers, and heparin. Or it could be due to renal failure, AKI, CKD, or acidosis like DKA, severe metabolic acidosis, or due to cell destruction like burns, crush injury, rhabdomyolysis, and tumor lysis syndrome, or it could be due to Addison syndrome. Or it could be to excess potassium like massive blood transfusion and excess potassium administration. All of this, you should understand all of them by just looking at here. You don't need to memorize, it's very obvious. However, there's some points you need to understand. ACE inhibitors and ARBs we mean aldosterone receptors blockers, aldosterone receptor blockers. The sartans group, losartan and whatever. ACE inhibitor is lisinopril group. These two lead to hyperkalemia. How? Because aldosterone, look, the liver produces angiotensin, which will convert to angiotensin 2, which goes to the kidney. From the angiotensin became renin in the liver, in the kidney, right? When it became renin will activate the aldosterone. When the aldosterone is activated, the aldosterone will bring sodium inside and put potassium outside. So if you have ACE inhibitor, that means you will block the effect of aldosterone. There will be no aldosterone. This will lead to the sodium will not come inside and the potassium will not go outside. When the potassium doesn't leave the renal tubule or goes to the urine, it will accumulate and this will lead to hyperkalemia. Okay, I hope I put an image for you to understand. Yes. So normal physiology. In the liver, there is angiotensinogen, which released from the kidney. Angiotensin the renin released from the kidney is transferred the angiotensin 1 to become the angiotensin 1. The angiotensin 1 become the angiotensin 2 by the effect of angiotensin converting enzyme, which will convert angiotensin 1 to angiotensin 2. Angiotensin 2 will activate the production of the aldosterone from the renal cortex. We'll come to that when we come to the endocrine. The aldosterone will lead to increased sodium resorption and increased potassium secretion. So when you cross this, when you here, as you can see when you cross the effect, this means there will be reduction in potassium secretion, and this will lead to hyperkalemia. Okay. Clinical picture: cardiac life-threatening arrhythmia. Just bear with me 1 second, guys. 1 minute. Okay. Do you see the screen? Let's continue. Okay. Neuromuscular will lead to muscle weakness and flaccid paralysis. Gastrointestinal will lead to abdominal cramp and diarrhea. And this is the management of hypokalemia. Okay. You have mild, moderate, and severe. Mild from 5. No, this is okay. Just bear with me 1 second. Let me just bring it from here. Management of hyper. Okay. All right. So hyperkalemia management. If the potassium is more than 5.5 millimole per liter, you ask yourself, is there any ECG changes or no? Okay. If there is ECG changes, so while you are on the ward and the nurse tells you this patient has hyperkalemia, his potassium is high, the very thing you think about is ECG. You immediately ask your patient to do ECG. If the ECG showed changes, you immediately give calcium gluconate IV. Okay? Calcium gluconate IV. After you give the calcium gluconate IV, why the calcium gluconate IV is important? Because you are protecting the heart. Very important. Then you give insulin plus glucose. Why? Because we said insulin takes the potassium from outside the cell and shove it inside the cell. And you can also add B2 agonist. However, in the recent guideline, this became controversial. However, we don't need to worry about this one. Just think about calcium gluconate and then insulin plus glucose IV. Usually, your answer for the exam will be calcium gluconate. All right. If your patient has what we call pseudo hyperkalemia, what does that mean? If your patient is taking this image is not that accurate. Wait a second. Let me just find a better image. Just bear with me 1 second. Sorry, guys. The image that I put there is not accurate. Let me just find a better image. You know what? I'm gonna speak from my head without the images from clinical point of view. If you have
الصورة في المنصة دي فيها التريتمنت بتاع الهايبركاليميا،
فيها شنو؟
فيها التريتمنت بتاع الهايبركاليميا.
اي لكن الصورة ما كرت فيها بعض الأخطاء الإملائية، عشان كده أنا ما كنت أعرض منها، لكن ما مشكلة. خليكم معي 1 second. All right. Just bear with me. So if it's mild, if you have a mild hyperkalemia, عندنا غلطة هنا يا جماعة، هي ما المفروض تكون هايبركاليميا، هي المفروض تكون هايبركاليميا. اوكي؟ الغلطة اللي هنا دي انتبهوا لها، ما في حاجة اسمها هايبركاليميا، دي المفروض تتصلح. فأنا حصلحها وبعد ذاك تاني أرفع عليكم إن شاء الله. اوكي. Initial assessment, assess the patient using ABCD approach. So you have patient with hyperkalemia, make sure your patient is breathing, he is not comatose, and he has a pulse. Okay? Because your patient may be in asystole or supraventricular tachycardia. In that case, you will treat your patient according to the ALS, advanced life support. Okay? All right. So you need to assess your patient. Then you ask immediately for 12-lead ECG and monitor cardiac rhythm. Exclude pseudo-hyperkalemia. We'll come to that in a second. Give empirical treatment for arrhythmia if hyperkalemia is suspected. The empirical treatment is you give calcium gluconate. Repeat urea and electrolyte and request creatine kinase if rhabdomyolysis is suspected, because rhabdomyolysis is one of the common causes of hyperkalemia. Review, stop any drug that may be contributing to hyperkalemia. Okay? Any drug that may be contributing to hyperkalemia. Meaning, you should stop what we mentioned earlier, like angiotensin converting enzyme inhibitors and all these drugs. Okay? Okay. If it's mild, 5.5 to 5.9, consider cause and need for treatment. You will still ask your patient, your nurse to do ECG just to make sure there's no changes. Dietary potassium restriction, prevent anything that has potassium like banana. Correct acidosis if there's acidosis. Consider diuretics, and in this case, we will consider the diuretics that lead to loss of the potassium if your patient need them. Okay. Consider fludrocortisone in type 4 renal tubular acidosis. We usually don't get to this one or this one. Usually will be the first and the second if there's no ECG changes. All right. If it's moderate, 6 to 6.4, treat guided by clinical condition, ECG and rate of rise, meaning like the rate of the ECG changes. If ECG changes, immediately shift the potassium into the cell. How? By giving insulin glucose IV infusion. Consider salbutamol, which will also shift the potassium inside. All of this after you give the calcium gluconate. If it's severe, more than 6.5, emergency treatment is indicated. You need to ask for help in that case. You give IV calcium, and then you shift the potassium inside. Okay? This image is not totally accurate. I'm going to change it for you. I want you to understand. So ECG hyperkalemia management, if you have potassium that's higher than 5.5, you immediately do ECG. All right? If there's any ECG changes, if it's low, if it's 5.9 or 5.8, you give calcium gluconate for any ECG changes, like hyperbaric T wave we spoke about earlier. Okay? And then after the calcium gluconate, if it's mild, meaning between 5.6 to 5.9, you don't need to give insulin or shift the potassium inside because it's already mild. All right. If it's moderate and there's no ECG changes, you give the calcium gluconate for protection, and then you shift the potassium inside by giving insulin and glucose. If it's severe, you call for help. You tell your senior. You ask for ICU bed. You give the calcium gluconate. You give the B2 agonist like salbutamol, and obviously you give the calcium gluconate as a start. All right. In your exam, the scenario will be patient presented with this, and that, and they will show you someone with severe or moderate hyperkalemia. And in the option, they will give you calcium gluconate, insulin, and beta-2 agonist like salbutamol. They wouldn't ask you which one will start first or last. No, they will tell you your patient has hyperkalemia, 6, and nurse did the ECG. The ECG showed big T wave. Which of the following medication will you give your patient? I want you to write on the chat here. B2 agonist like salbutamol, insulin plus IV glucose, or calcium gluconate. Write for me here. Why I can't see the messages? Why? Calcium gluconate, okay. But calcium gluconate doesn't solve the issue, right? Does it? Calcium gluconate
Doctor,
doesn't.
can you repeat the question?
مصطفى ركز. Focus.
تمام.
You have a patient who has hyperkalemia. ECG showed changes. What medication will you give? Calcium gluconate, IV glucose plus insulin, or salbutamol?
Calcium
What do you-
gluconate.
Or
Okay,
salbutamol.
we'll write it.
Yes. I want everyone to write, guys. Just write, please. Write in the group. Those who are not writing, did they leave the recording? Where are you, Mariam Gidam? شكله خلوا التليفون ومشوا. Calcium gluconate. Yes, the answer is calcium gluconate. Why? You may think I should give the potassium. I should give the glucose and insulin to get the potassium fast inside the cell. However, the issue is you want to protect the heart. You should protect the heart first with calcium gluconate. Okay. I'm not going to spend much of this one. And for the treatment, I will upload a good image. Let's find it now so we don't forget. But the previous one was not accurate. Nice guidelines 2026. Yeah, this is accurate. Okay, let's take it here. Okay. All right. Acute, mild potassium supplement. Low diet, okay. Monitor potassium, prevent recurrent. Acute. No. Yes, this is accurate. Fine. All right. So, however, I don't want you to memorize everything written. No, I just want you to understand because your exam obviously will be about was it safe or not? Your exam will be just giving about the calcium gluconate, okay? That will be the most important one. So you don't need to memorize every single thing written here on this table. Just understand what's going on, and the answer will be potassium gluconate, calcium gluconate. Okay. After the potassium, I'm gonna discuss the rhabdomyolysis, which has a lot of things to do with hyperkalemia. Okay, so rhabdomyolysis means rhabdo meaning muscle, myo rhabdo meaning skeletal, myo mean muscle, lysis mean destruction. So rhabdomyolysis breakdown of skeletal muscle leading to release of intracellular content into the bloodstream, especially myoglobin, creatinine kinase, potassium, and phosphate. This can lead to acute kidney injury, electrolyte disturbance, and cardiac arrhythmia. It could be due to traumatic causes, crush injury, compartment syndrome, major trauma, and prolonged immobilization. Excretional cause could be marathon runners, extreme exercise, and heat stroke. All right. Other important causes: seizure, drug. Why seizure? Because you will be doing this in seizure. This may lead to rhabdomyolysis, alcohol, and infection. Clinical picture: your patient will present with severe muscle pain, muscle tenderness, muscle weakness, dark urine, tea colored or Coca-Cola colored urine, reduced urine output, oliguria. There will be dehydration, swollen tense muscles, feature of compartment syndrome may coexist. Investigation: blood test, creatine kinase. Increasing creatine kinase is the most important marker. Creatine kinase more than 1,000 international unit indicates significant muscle damage. Very high level strongly suggest rhabdomyolysis. Okay. So, from clinical point of view, I'm just going to give you all our experience. If you have a patient, so not every creatine kinase elevated, you should think rhabdomyolysis. For example, you have a lady who had a neck of femur fracture, and she fractured it and she was laying down. We call it long lie. So the lady was in the floor for 6 hours because she was not able to call the ambulance. This lady who had a long lie, which means she was lying on her muscle, the thigh or the gluteus, for hours, will have high creatine. This is not rhabdomyolysis. Rhabdomyolysis, okay? This is long lie. If you have a patient with long lie has high CK, creatine kinase, you need to stop statins because statins may affect the muscles. Okay. All right. Very high level strongly suggested rhabdomyolysis. Myoglobin, increase in serum myoglobin. Myoglobin released from the damaged muscle. Electrolytes will be hyperkalemia, hypocalcemia, and hyperphosphatemia may occur. Renal
Dr.
function. Yes, Mustafa?
About the long lie.
Yeah.
Okay, why 6 hours lead to increased creatine kinase?
Because
of
if the lady was lying on her muscle, this if she broke her neck of femur fracture, neck of femur fracture, and she was lying down on her buttocks, for example, Mustafa, or her right thigh or her left thigh, there will be high pressure, there will be reduced blood supply to these parts, and then there will be muscle necrosis. This will lead to some increase of creatine kinase. Okay?
due to the fracture. Yeah.
Not due to the fracture itself, due to the compression on the muscles. There will be some muscle died because you will be lying,
Yeah.
putting her whole weight on a specific area.
Because I was asking myself when we sleep like 6 hours.
So when you
Why
sleep
not?
6 hours, when you sleep 6 hours and you wake up directly, your creatine will be a bit high, creatine kinase. You drink water, you walk around, it will come down.
Okay.
However, the
Got it.
point you mentioned is completely right. So in addition to the pressure on the muscle, the fracture itself also will have some impact on the muscle. The bone literally will be
Okay.
crushing on the muscle. So you are right. The effect of the lie and the effect of the pressure from the bone on the muscle. You are totally right.
Okay.
Okay.
Great. Thank
Urine finding, there will be dark urine and myoglobinuria. Important electrolyte problems with this rhabdomyolysis. There will be hyperkalemia, which can lead to fatal arrhythmia, sudden cardiac arrest. ECG changes will be big T wave, which is already mentioned, is correlated to hyperkalemia, and wide QRS complex. There may be hypocalcemia. This may lead to muscle cramp, tetany, and arrhythmia. My question is, why there is hypocalcemia in rhabdomyolysis? Don't you think this lecture will be just teaching you? I'm gonna ask a lot of questions. Let me make sure Rania is following. Rania,
يا دكتور علي سامع.
yeah, okay. Can you search on the internet for us?
For
Why
what?
rhabdomyolysis causes hypocalcemia?
I thought there is consumption of the calcium
But how?
by formation of lactic acid. يعني
Is it by the formation of lactic acid or by the phosphate running in the blood? Because there will be hyperphosphatemia, right? So
hyperphosphatemia.
I want you to look it up. Remind me and remind yourself.
Okay.
Can you just look it up now?
Okay.
معلش يا جماعة
Code
ده رح
no problem. كويس عشان الناس ما تسرح ذاتها.
try to check.
Causes of hypocalcemia.
In rhabdomyolysis.
Okay.
Mustafa also do the same.
كنت عايز تحك رقبتك ولا شنو؟
حق ضاني everyone search.
طيب hypocalcemia. دقيقة.
Yeah.
راحت اختفت جوجل. دقيقة. causes أيوة
Rhabdomyolysis causes hypocalcemia primarily due to massive muscle tissue damage, where release of intracellular component to the bloodstream and shift the body calcium balance. All right. The calcium influx into damaged cell where skeletal muscle cell die. Calcium phosphate. I told you that, right? Do you remember? So due to calcium phosphate, and the calcium will come inside the cell. Why the calcium will come inside the cell? Whoever answered this question, that means he's like legend. Why, when the cell is damaged, the calcium comes inside? Why?
عشان potassium.
No, because you need the calcium for apoptosis. Do you remember apoptosis? We say apoptosis, it's not apoptosis, apoptosis. You need the calcium for apoptosis. That's why when the cells start to, and even for necrosis, that's what. So the main reason for the hypocalcemia is two reasons. Firstly, there's high phosphate running because the cell being damaged and the phosphate is running outside. It will come and bind to the phosphate. Calcium loves phosphate. This is the first reason. Second reason, the calcium will leave and enter the cell for the apoptosis and for the necrosis. Okay, very important. All right, complication. Renal complication, acute tubular necrosis caused by myoglobin precipitated inside the renal tubules, renal vasoconstriction and hypovolemia. Can progress to acute kidney injury. Cardiac complication, severe hyperkalemia, ventricular arrhythmia, and sudden cardiac death. Local complication, compartment syndrome. Treatment. Initial priority, ABC assessment, airway, breathing, and circulation. You manage the hyperkalemia, as we mentioned before, how to manage the hyperkalemia. Fluid resuscitation, main treatment, aggressive IV fluid, large volume isotonic saline. Goal, maintain renal perfusion and flush myoglobin from kidney, prevent AKI. Monitor urine output, renal function, an electrolyte. Alkalization of urine, very important. Why? Because you have high potassium running outside, so the kidney will push the H plus outside. So you need to alkaline it. IV sodium bicarbonate, by giving IV sodium bicarbonate. Alkalization of the urine will reduce the myoglobin precipitation in the renal tubules, and this will protect the kidney. So we'll alkalize the urine. Think about it like the acid, the H plus that the body is pushing out will damage the kidney. So we have to alkalize it. Literally, think like you put acid on your kidney. You need to alkalize it to make it neutral. Additional management, treat underlying cause. Relieve the compartment syndrome. How do we relieve the compartment syndrome? How do we relieve the compartment syndrome? Quick, fast, guys. Answer. How do we relieve compartment syndrome?
Fasciotomy.
Fasciotomy. Fantastic. Good. Stop offending drug and treat trauma. Serial CK level, potassium, calcium, renal function, ECG monitoring. All right. For your exam, dark urine, muscle pain, and increased CK, think rhabdomyolysis. Hyperkalaemia is the most life-threatening complication of rhabdomyolysis. Acute tubular necrosis is a major renal complication. Early aggressive IV fluid is the cornerstone of treatment. IV calcium gluconate is given first if severe hyperkalaemia is present. These 4 points, if you have 2 minutes and your exam is tomorrow, don't read all of this, just read this. Okay? Fantastic. Let's move to the next. I'm not gonna give you the hyponatraemia now. I'm gonna start with why I'm not able to move this one. That's so strange. Just bear with me. I will start with Tumour Lysis syndrome, okay? Because it also has a relation with hyperkalaemia. Tumour Lysis syndrome is a life-threatening oncological emergency caused by rapid destruction of tumor cell with release of intracellular content of the bloodstream. This will lead to hyperkalemia, hyperphosphatemia, and hyperuricemia and hypocalcemia. Why hypocalcemia? Same mechanism we just mentioned, right? So the hypocalcemia will be due to the calcium coming inside the cell for the apoptosis and the necrosis, and also the phosphate that left the cell will bind to the calcium, and this will lead to hypocalcemia. والله يا جماعه مرات كده انا بحس بروحي استاذ رهيب عديل والله. رايكم شنو؟
الحقيقة
يا
ما
اخي
شاء الله بتقدر توصل المعلومة دكتور، ما شاء الله.
قاعد
حاجة
لكم
كويسة.
قاعد كده تشب لما الا الزول الا تكون ما دار تفهمها والله. Okay, let's continue. Stop the bragging. This may result in arrhythmia, seizure, or acute kidney injury. When this will happen, so the tumor lysis syndrome will happen in cases of after chemotherapy due to rapid destruction of malignant cell after treatment, high proliferation tumor like Burkitt lymphoma, acute leukemias, and high-grade lymphomas. All right, here I'm just giving you some physiology of the fluid compartment. Why? Because I want to speak about the edema after that. So I don't want you to memorize any of this. I want you just to look at this small table here, this one. So the total body fluid is around 60%, meaning 42 liters. Wow, that's so crazy. That's mean if we crush someone here, he will produce 42 liters of water. Okay, that's so. Think about it. 42 liters of water. Okay, the intracellular fluid is 28, the extracellular fluid is 14, the interstitial is 10, and the plasma is 4. Okay, this is your body fluid. These numbers they may ask you about them. Just memorize this one, nothing else. Don't look at the rest of the image, not important. All right, edema. IV fluid mainly increase intracellular fluid volume and plasma volume first. Okay, this is the effect of each medication or of each drug. Why we put it here? Because they may ask you about it. So if you gave your patient glucose 50%, 5% or free water, this will increase the extracellular volume and will lower the osmolality. Why? Because more water moves into the cell and causes dilution of the extracellular compartment. كلام عديل, very makes sense, doesn't need explanation. Normal saline increase the extracellular fluid volume. However, osmolarity will remain the same because saline stands mainly in the extracellular compartment. Sodium does not freely enter the cell. Okay? I don't think there will be a question. I don't think. Edema. Definition is excess fluid in the interstitial fluid compartment. Very important. If you want to understand, here the plasma, here you have the interstitial fluid, and here you have the intracellular fluid. This image explains everything. There are some causes of edema. We call it pan edema due to hypoalbuminemia mechanism. There will be reduction in the oncotic pressure, and the fluid leave the plasma into the interstitial space. Okay, so here inside this artery or inside this vessel, there's oncotic pressure and there's hydrostatic pressure. Hydrostatic pressure push the blood outside, push the fluid outside, and oncotic pressure push the blood inside, push the fluid inside. Okay, the oncotic pressure is mainly due to the protein, specifically the albumin running around here. If you have hypoalbuminemia, meaning the albumin is low here, that means the oncotic pressure will be low. This means the fluid will leave from here coming to the outside. When the fluid leaves from here coming to the interstitial fluid, that's the definition of the interstitial of the edema. Okay. Also, another cause of edema is increasing the hydrostatic pressure here. If the hydrostatic pressure increased around here, this will push the fluid outside to the interstitial fluid. Okay. Inflammatory edema increase capillary permeability mechanism, protein and fluid leak into the tissue, more interstitial fluid accumulation. If you have endothelial injury here, or the permeability meaning المساحية أو الفراغ increase here, that means the albumin will come outside. If the albumin came outside, that means the fluid will flow it. Why? Because it's the oncotic pressure, meaning the oncotic pressure which was supposed to be here now became outside here. This will lead to edema. Okay, I don't want you to memorize any of this. I just want you to understand the mechanism of it. Okay, and you can have this table, have a look at it, also not for memorization, for understanding. Okay, from clinical point of view, I want you to differentiate between beating edema and non-beating edema. Beating edema, when you press for 50 seconds and then you release, it become like this. Non-beating edema, when you press and then you release, it become like this. Okay, that's the difference between beating edema and non-beating edema. Where do we find non-beating edema? And where do we find beating edema? Non-beating edema usually in lymphedema, and beating edema usually in heart failure. Beating edema, okay? I don't want the lecture to be long. Let's continue. Let's finish. All right, so we spoke about both. Now we're going to speak about the, let's just read this here. Now we're going to speak about the hyponatremia quickly, okay? So sodium, next important one. Hyponatremia, serum sodium less than 1.35, less than 135 millimole per liter, and hypernatremia, serum sodium more than 145 millimole per liter. All right. How you approach? Let's say your patient has sodium of 134 or 127. How you approach it? First step, check the serum osmolality. Normal osmolality 275 to 259. Why is that? To exclude pseudo-hyponatremia. How? Pseudo-hyponatremia could be due to hyperlipidemia or hyperproteinemia. If you have high lipid in the serum and you have high protein in the serum, this will increase the oncotic pressure. This will lead to fluid coming inside. If the fluid coming inside, that means there will be hyponatremia. لو عندك عصير وضفت له مويه هيبقى مسيخ. That doesn't mean انه العصير من البدايه كان مسيخ. So the idea is there is hyponatremia. However, the sodium was not low, the sodium was normal. But because your patient has hyperlipidemia or your patient has hyperproteinemia, this absorbed the fluid and brought it to it. When the fluid came, it diluted it and then led to hyponatremia. That's why we call it pseudo hyponatremia, meaning not real. All right. Let me just 1 second, guys. Sorry. So, if you have hyponatremia and the osmolality is normal, that means pseudo hyponatremia. Okay. If you have high osmolality, meaning if you have hyponatremia and the osmolality is high, that means your patient has either hyperglycemia or he has unmeasured osmol like glycine and mannitol. So we use glycine for transurethral resection of the prostate. You literally use glycine. When this glycine goes to the body, it will increase the osmolality and it will drag the water with it. So your patient will have hyponatremia. العصير هيبقى مسيخ. However, the osmolality will be high. Okay? The osmolality will be high. If it's low osmolality, so if you had hyponatremia and low osmolality, you need to take the volume assessment. Meaning you need to see if your patient is overloaded or dehydrated. All right, let's talk about the volume assessment. How you assess the volume of fluid in your patient? By postural pressure, blood pressure, and pulse, jugular venous pressure, if there's any edema, if there's any ascites, if there's skin. If your patient has ascites and has edema and the GVB is distended, that means he's overloaded. Okay? All right.
Did you talk about mannitol?
Mannitol is the same idea. Think about mannitol and glycine. What does mannitol does, Mustafa? Mannitol is osmotic.
Will
So it
take
does,
the water to its side.
yes, same as glycine, same effect. Okay? So it will lead to hyponatremia. However, the osmolality will be high. Okay? All right. Hypovolemic. Okay. We said if there is low osmolality, we'll do the volume assessment. For the volume assessment, you check this. If your patient is hypovolemic, meaning there's no ascites, there's no edema, GVB is not distended, and the skin is dry, that means there is total body water reduction or there's total body sodium reduction. How you determine that? By checking the urine sodium. Extrarenal sodium loss, the urine sodium will be less than 10 millimole, and the urine osmolality will be more than 100 milliosmol per kilogram. So you will have a scenario, they will mention these numbers for you just to reach the diagnosis. Okay? Causes: extrarenal sodium loss, meaning the urine sodium is less than 10 millimole. That means the kidney didn't lose the sodium. We lost the sodium from other places, not from the kidney. Why? Because when we check the sodium in the urine, the sodium was less than 10 millimole. Like if you are urinating sodium, that means we will see it, right? Do you understand? So the urine sodium check will tell you if we lost the sodium from the kidney or from other sources. If we find the urine sodium less than 10 millimole, that means we lost the sodium from outside the kidney, not from the kidney. All right? Do you understand? Yeah. Okay. What are the causes of losing urine from outside the kidney? Vomiting, diarrhea, or from third space like pancreatitis, bowel obstruction, and burns. By that we mean when you have hemorrhagic pancreatitis, you may lose fluid. When you have bowel obstruction, there's no absorption of the fluid. And when you have burns, there will be papules and vesicles. You will lose a lot of fluid in burns. All right. So we either lose the sodium from the other side of the kidney, and this will be the causes, or from the kidney. If we lose the sodium from the kidney, there will be a lot of sodium in the urine, right? The urine sodium will be more than 10 millimole. I don't want you to focus on this. I want you to focus on this. This is one important one. Causes: diuretics, Addison disease, salt wasting nephropathy, and proximal renal tubule acidosis. Diuretics will lead to increasing the sodium, right? The main effect of diuretic is putting the sodium out, and then you lose it through the urine. All right. We will come to Addison disease in the endocrinology. However, what is Addison disease? What is Addison disease? Addison disease is adrenal insufficiency in a way. So you won't have aldosterone. Aldosterone will lead to absorption of the sodium and pushing of potassium. So when you don't have aldosterone, the body will not absorb the sodium. That means the sodium will come outside. That means you will lose the sodium. And when you lose the sodium, it will appear in the urine. All right, this is a treatment, not that important. All right, how you treat the hyponatremia? Treat the underlying cause, stop the diuretic, steroid replacement if the patient has Addison disease because it's adrenal insufficiency. That means your patient has no steroid. Restore volume with IV crystalloid. If it's symptomatic, give 1 liter 0.9 saline over 2 to 4 hours. Monitor sodium every 1 to 2 hours. If it's asymptomatic, gradual correction with 0.9 saline. All right. All of this is about the hypovolemic hyponatremia. We still have euvolemic hyponatremia, meaning the total body is fine, is increased. However, the total body sodium is normal. The volume of the water in the body is neutral. Okay, just 1 second. Just bear with me 1 second. Hypovolemic, we spoke about that. Total body and total sodium. Total body water is, sorry guys, come on, then I reverse this one. This should be here, and this should be down there. Total body sodium. No, down. All right. So the total body water is the same. Total body sodium is down. Low urine osmolarity. There will be low urine osmolarity. Finding the urine sodium will be more than 10 millimole. Okay, that means you lost a lot of sodium in the urine. That's why you have hyponatremia. And the causes for that is water intoxication, meaning you drank a lot of water. By psychogenic polydipsia. Psychogenic is psychogenic, means psychosis. Polydipsia meaning drinking a lot of water. Ecstasy, intoxication, will also lead to that. And marathon runners will also drink a lot of water. And beer, botomnia. Beer, like the beer, when you drink beer. So the causes of low urine osmolarity with euvolemic hyponatremia, in which the sodium will be high and the urine osmolol will be less than 10 milliosmol per kilogram, are due to water intoxication. If you have high urine osmolality, there will be 2 causes, either siyada or drug medication like antidepressant, antipsychogenic, carbamazepine, an opioid, non-steroidal. All right. Let me just summarize this for you guys and tell you how your exam will go. They will give you a scenario. They will give you the osmolality. they will give you hypovolemic or hypervolemic, and they will give you the sodium in the urine. Is it more than 20 millimole or less than 20 millimole? And they will ask you what is the causes. So all of this, I'm just gonna summarize it for you in a table later on. So you need to come later on, summarize this in a table. I will summarize it for you in a table after the lesson, because the lesson is taking too much. I'm not gonna do it now. So later on I will put a table for you here. Okay. All right. This is the hyponatremia. Hypernatremia, meaning serum sodium less than 145 millimole. Water causes water loss or sodium loss due to diarrhea, sweating, pains, diabetic insipidus, and osmotic diuresis. Or sodium gain, meaning due to hypertonic saline. If someone had hypertonic saline, mean a lot of saline, sodium bicarbonate, or excess salt intake. Clinical feature: thirst, confusion, irritability, weakness, seizure. Both of them, hyponatremia and hypernatremia, has similar presentation. It doesn't differ much. Okay. Treatment: correct slowly, oral water if possible. If hypotonic fluid, IV hypotonic fluid like 5% dextrose and 0.5 saline, and treat the underlying cause. Why we correct it slowly? We correct it slowly because we want to avoid a very important syndrome. Okay? Here, this is a treatment summarized for you guys. Oh, yeah. All right. Okay. So this is the hyponatremia. I put it on you in a table here. Okay. This hyponatremia and how to deal with it. So if you have normal osmolality, high osmolality, and low osmolality. If it's high osmolality, take the volume assessment. Okay. Then you have hypovolemic, and you have eovolemic, and you hypervolemic. Each one you have different subcategories for it: high urine sodium and low urine sodium. Unfortunately, I wish if I can make it simpler than this, but this table is a must to read through. Very important. All right. So why we correct it slowly? We correct it slowly to avoid demyelinosis of the cord. Think about it. If your sodium is low or high, that means the cells in the brain get used to a specific sodium. Okay? Central pontine demyelinosis. Just bear with me 1 second. Central pontine myelinosis, also known as osmotic demyelination syndrome, is a neurological condition characterized by damage of the myelin sheaths in the bones and vital area of the brain. Rapid sodium correction. All right. The brain adapts to chronic low sodium by adjusting its own internal osmolarity. So, if you have a brain, if you have hyponatremia, your brain will get used to the low sodium. Okay? Your brain will get used to the low sodium and will adapt with it. If you suddenly put a lot of sodium and correct it very rapidly, that means the fluid, because your brain has low sodium, will go from your brain to the outside, to the fluid, to the interstitial, to the intravascular. That means you will suck water from inside. This sudden active sucking of the water, because the water follows the sodium, will lead to demyelination of the spinal cord. Okay, that's all what you need to know about why we corrected it slowly and not rapidly. Okay, let's save this one. Okay, so we have still سيادة. I'm going to speak about the سيادة. I will give you break, guys. أقدر أصلي المغرب برضه. I want to pray. Give you break 4 minutes, and then we come and finish this lecture. Oh, 2 hours already, man. No, not 2 hours. Sorry, 1 hour and a half. So we'll finish maximum in 2 hours. So we have half an hour. We will come tackle the siyada, the magnesium, the calcium, and the magnesium and chloride. Okay. So you have half an hour break. Not half an hour, 5 minutes break. السلام عليكم يا شباب، يلا نواصل. بسم الله. نواصل من محل ما وقفنا. وصلت لهم في الجروب انه خلاص بدينا. طيب نبدأ بسم الله. طيب calcium. All right. Hypocalcemia definition: low serum calcium, usually total calcium less than 2.2 millimole per liter, or ionized calcium less than 1.1 millimole per liter. Causes: both thyroidectomy, which when you take the thyroid, there's likeliness you take the parathyroid. Acute pancreatitis, magnesium deficiency, respiratory alkalosis, vitamin D deficiency, chronic kidney disease, and massive blood transfusion. Why massive blood transfusion lead to hypocalcemia? Because when you have massive blood transfusion, there will be citrate in the blood binds to calcium. All right. Clinical feature: latent tyranny. There will be Jovistic sign and Trousseau sign. Jovistic sign, when you press on the patient here on the cheek, the patient will clench. There will be lip twitch, eye blink, and nose twitch. How you memorize it? Jovistic cheek. The CH in Jovistic is the same CH in cheek. All right. So when you press on the cheek, that's Jovistic. Okay. You have also Trousseau syndrome, which is place a blood pressure cuff on the upper arm. Your patient will have carbopedal spasm. All right. We call this Trousseau syndrome. How I memorize it? Trousseau is like a trimmer, like he doing his hand like this. I know the way I memorize is stupid, but I don't like this is, So Trousseau from trimmer like this, and Jovistic from cheek. Okay, this is how you memorize both of them. Okay. There will be perioral numbness, muscle cramps, carbopedal spasm, convulsion, and laryngeal spasm. All right. The ECG changes for it will be prolonged QT interval. You need to memorize this one, and I have an image for it later on. I will show you. Important modeling guideline point: always check magnesium. Hypomagnesemia can cause hypocalcemia resistant to treatment. You know why? Because the parathyroid gland, in order for it to work, the magnesium receptor should be intact. So if you have a patient and the parathyroid is not working, the parathyroid hormone goes to the bone وبنخر في البون, break down the bone to increase the calcium. And it's the main source of calcium in the body is the bones, in the bones. If the magnesium is low, the parathyroid gland will not work well, and this will lead to parathyroid hormone not being active, leading to you will not be able to absorb bone from the most important resource of the bone, which is you will not be able to absorb calcium from the most resource of the calcium, which is the bone. That's why you need to check the magnesium. Management of hypocalcemia: if it's mild, oral calcium supplement, vitamin D, usually calcitriol in CKD. In severe, if there's how we determine the severity: tetany, seizure, arrhythmia, prolonged QT, or laryngospasm, we give IV calcium gluconate. All right. You give 10 millimole of 10% calcium gluconate, given slowly IV over 10 minutes. Cardiac monitoring is required. Hyperglycemia is adjusted calcium more than 2.6 millimole. All right. We have what we call corrected calcium formula. Why corrected calcium formula is important? Because the calcium in your body is binded to albumin. When you measure the calcium, when you take a sample of blood of your patient, if the albumin is high, this will lead to high calcium. If the albumin is low, this will lead to low calcium. That's why we need an accurate reading. Do you understand this point? Why do we need to correct the calcium? Do you understand this point I just mentioned? Put thumbs up if you understand what I just said. If you don't understand, open your mic and tell me. All right, Safwat, Rania, Mariam, Mustafa, and Adil.
I don't understand.
You don't or you do? Mustafa? You don't? Okay.
Yes.
Understand or don't understand? You want me to explain it again?
Yes.
All right. This is the calcium, white color. And this is your albumin. They bind together in the blood. Okay?
Yes.
When you take a sample of blood and you measure the calcium. However, you only measure the calcium with the albumin binded to it. If the albumin is low, that means you will not be able to catch a lot of calcium. That means this is false reading for you.
Yes, sir.
Do you understand?
Yes.
Fine. And if albumin is high, that will also give you a false reading. This will tell you the calcium is reading. The calcium is high also. So how to correct it? You correct it with this one, which is serum calcium plus 0.8 multiplied by 4 minus serum albumin. All right. Why did we put these numbers? Each number has an explanation. So the normal serum albumin is 4. Okay? So
Okay.
if the serum albumin is 4, the normal number, that means 4 minus 4 will equal 0. So the effect of serum albumin is taken out. If the serum albumin is 5, serum albumin is 3, for example, that means 4 minus 3 will be 1. That means the serum calcium will increase by 0.8. Okay? This will correct your serum calcium. How? Because your serum albumin is low already. That means the reading you see is not correct. That means the reading you see is lower than what it should be. If it's 3 here, 4 minus 3 is 1. 1 multiplied by 0.8. You add it to the serum calcium, that will give you an accurate reading. Why? Because the serum albumin is low, which will give you low reading than it should be. And if you apply this formula, it will get you to the right number. All right, we know where the 4 came from. The 4 came from the serum albumin being normally 4. Where does 0.8 come from? 0.8 used because the serum calcium changes by about 0.8 milligram per deciliter for every 1 gram deciliter change in the albumin. Here, this sentence here. So we understand exactly where this number came from. It's not like random numbers. The 4 is the normal number of serum albumin. 0.8 is the rate of change. If the albumin reduced by 1 gram, meaning if the albumin is 3, that means the sodium will be low by 0.8. Okay? And if the albumin increased by 1, that means the calcium will be increased by 0.8. Okay? I hope this is clear. Let me just put my charger on. So I want you to memorize this table here. So this table is for memorization and to understand where the 0.8 came from and where the 4 came from. Okay. Most common causes is primary hyperparathyroidism, malignancy, especially breast cancer, multiple myeloma, vitamin D excess, sarcoidosis, and milk alkali syndrome, and thiazide diuretics. Sarcoidosis produce an enzyme that will activate vitamin D. Okay. Clinical feature of hyperkalemia: bones, stones, cones, psychiatric overtones. Bones mean they will be bone pain. Stones mean they will be renal stone and polyuria and dehydration. Groans mean like belly pain, gastrointestinal abdominal pain, constipation and nausea. Psychiatric overtones mean confusion, depression, and fatigue. Here are the ECG of both. Okay? ECG of most important ECG you need to memorize. This is a normal ECG. This is the ECG of hypokalemia. This is the ECG of hyperkalemia. This is the ECG of hypocalcemia, and this is the ECG of hypercalcemia. Most important changes. This image is for memorization. Management of hyperkalemia. Correct calcium, 2.6 to 3 millimole. If it's mild, 2.6 to 3 millimole, you treat the underlying cause, you stop the calcium and vitamin D, you encourage oral hydration, and you monitor calcium and renal function. No urgent IV therapy usually needed. If it's moderate hypercalcemia, meaning from 3 to 3.5, you give IV 0.9 normal saline, correct the dehydration, monitor fluid, and monitor urine output. If calcium remain high after rehydration, give IV bisphosphonate. Why? Because the bisphosphonate takes the sodium and put it inside the bone. All right? If it's severe hypercalcemia, correct the calcium. By severe hypercalcemia, we mean more than 3.5. Urgent treatment. IV 0.9 normal saline first line. Correct dehydration. Add IV bisphonate, like zoledronic acid or pamidronate. Bisphosphonate effect take 24 to 48 hours. Okay. You can also add calcitonin for rapid temporary reduction. Why? Because the bisphosphonate takes time. Give steroid if due to sarcoidosis, vitamin D intoxication, or hematological malignancy. Dialysis if severe refractory. You can use dialysis. Okay. Here, what is the, in summary, you have another table here just to summarize. I'm not going to go over it. The lecture is taking way longer than what it should be. Let's just quickly finish. Okay. This is a calcium. Did I already spoke about Siyada? No.
No.
So all I want you to know, what did you say, Mustafa?
No, you didn't speak about it.
Fine. For Thiada, I'm not gonna say much. It's a syndrome of inappropriate antidiuretic hormone. All right. It has causes. All what I want, this is the causes for it. All right. This is a syndrome of inappropriate antidiuretic hormone secretion, meaning there will be a lot of antidiuretic hormones secreted inappropriately. Meaning your patient will not urinate as much, meaning the water will accumulate and your patient will have hyponatraemia. Okay, so what I want you to memorize, and the high yield point for hyponatraemia, is they may present it for you as a test and they will give you readings. Okay, this is so Siyada is very common with lung cancer. Okay, this is a very high yield point. Siyada is very common with lung cancer. Let me see, where did I write it? Malignancy, paranephrotic syndrome, yeah, small lung carcinoma, small cell lung carcinoma. This is very important because they will give you small cell lung carcinoma and they will give you squamous cell carcinoma. Squamous cell carcinoma is very common with hypercalcemia. Okay, so just memorize this one here and read the rest. Unfortunately, the lesson is taking too long. You just need to go through all of this. There's nothing to understand. All of it, most of it is memorization. And here's a timetable, a small picture explaining the Siyada syndrome. Okay. We finished the calcium already. And then we're gonna finish by magnesium. It's not that.
Dr. Ali,
Yes, Mustafa.
just please write the other type of lung cell carcinoma. If
We
you
have
permit.
we have it. Don't worry, we have it in the pathology. I will tell you exactly the paraneoplastic syndrome of each one, Mustafa. Don't worry about it.
Okay.
Okay, don't worry about that. I will tell you exactly what paraneoplastic syndrome causes which one. So the squamous hypercalcemia. All right, but we'll come to this later on. All right. For the magnesium and chloride, it's not that high yield. What I want you to memorize, and I already told you about, whenever you correct the hypocalcemia, always correct the magnesium with it. Why? Because the magnesium is very important for the receptor of parathyroid. And parathyroid produces the parathyroid hormone, which breaks the bones and increase the calcium in the body. All right. Magnesium, the largest store is in the bone. Then muscle. Normal serum magnesium is 1.7 to 2.2. Hypomagnesemia, magnesium below 1.7. Cause the reduced intake, like anorexia and malabsorption, excessive loss, like diarrhea, stomach output, fistula output, NG loss, or renal loss. Associated condition, I give you the condition and why. Chronic alcoholism due to poor intake and increased renal magnesium loss. Ketoacidosis due to osmotic diuresis causes excessive urinary magnesium loss. Due to ketoacidosis, you will lose the magnesium. Parathyroid disorder, abnormal parathyroid disturb mechanism balance and renal handling. Low vitamin D reduces intestinal absorption of magnesium. Acute pancreatitis, magnesium is trapped in area of necrosis. So when you have acute pancreatitis, there will be what we call saponification. The saponification will lead to hypocalcemia and also hypomagnesemia. Refeeding syndrome, we said when the person is malnourished for a long time, he didn't eat or drink for a long time, and then he started to eat quickly, this will lead to the body acting, producing insulin and absorbing all the electrolytes. This will lead to hypocalcemia, hypomagnesemia. Refeeding syndrome will lead to reduction of everything. All right. Here you have drugs and the mechanism of it causing hypomagnesemia. Clinical picture. Usually, it will not develop unless the magnesium is less than 0.5 millimole per liter, as you can see here. So if you have a magnesium of 1.6, that's hypomagnesemia. However, it will not be symptomatic. The symptoms usually appear around this number. And what are the symptoms? Gastrointestinal, anorexia, nausea, and weakness, confusion, ataxia, paresthesia, tremor, drowsiness, and coma, tetany, muscular vasculation. So if you are studying and your eye started to twitch like this, which sometimes happens to me like this, here, sometimes your body will start doing this and this will start twitching. It's either caffeine intake, you have high caffeine, or you have hypomagnesemia. Okay? These are the main two causes of it. It may lead to cardiac arrhythmia and it may lead to digital toxicity. Treatment of hypomagnesemia, oral magnesium replacement. All right? If it's severe or symptomatic, like the patient has arrhythmia or seizure or tetany, then you give IV magnesium sulfate. Important note, correct associated hypokalemia and hypocalcemia. So think about it. Think about magnesium, potassium, and calcium together. Whenever you find one of them low or high, you need to think about the other. And if you corrected any of them, you need to correct the others. Treat the underlying cause and monitor with renal function. Okay? Hypermagnesemia is not important, not high yield, doesn't come to your exam. Don't worry about it. Normal chloride, so chloride. So we have hypochloremia and hyperchloremia. Normal chloride is 96 to 0.6 milliequivalent per liter. Hypochloremia, low chloride level, which mean less than 96. It could be due to vomiting, congenital hypertrophic polaric stenosis. So we mentioned this before, if you remember, CHEPS, congenital hypertrophic pyloric stenosis, and gastric outlet obstruction. If you think about these three, they are the same. Vomiting is vomiting. Congenital hypertrophic pyloric stenosis will lead to vomiting. Gastric outlet obstruction will lead to vomiting. Okay. Hyperchloromic, hypokalemic metabolic alkalosis. This is the main feature of this one. Characteristic feature, there will be paradoxical aciduria. So if you have metabolic alkalosis, the HCO₃, the bicarbonate, should increase. The urine should be alkalitic. Why? Because you are producing, your body is alkalotic, so the kidney should push hard to take the HCO₃, the bicarbonate, and push it outside. Okay? In this case specifically, in hypochloremia, there will be paradoxical aciduria. Why? The body will push the H plus outside. Why? Because you have hypochloremia, meaning the Cl minus is low. You need to push the H plus outside for balancing. And it has a very complicated pathophysiology. Potassium is also involved. I will tell you the details of this one when we come to the renal physiology. Just bear with me when we come to the renal physiology. All what I want you to know now, with hypochloremia, there will be paradoxical aciduria. Treatment, you give IV normal saline, potassium replacement, and treat the underlying cause. Why you give potassium replacement? Because there is hyperchloromic, hypokalemic metabolic alkalosis. So the potassium is low. All right. Hyperchloremia is usually due to urinary diversion with ileal conduit or excessive saline intake administration. Why? Because saline is sodium plus chloride, right? So when you give your patient a lot of sodium chloride, that means you're giving him chloride. This may lead to hyperchloremia. For hyperchloremia, there will be hyperchloromic, hypokalemic metabolic acidosis. Okay? How to treat it? You will stop. Yes, Mustafa?
What is urinary diversion with ileal conduit?
So sometimes if you take the blood of a patient with a surgery, and you want the ureter to drain to somewhere, you will do this procedure. Okay? Do you understand?
Yes, we'll change the bypass or something.
Yes. Let me show you. Do you see?
From the ureter to the ileum.
Yeah. Do you see the image?
Yes.
Nazallah salama. Okay. I'm so glad you asked about it. So let's put it here. All right. Acid-base disturbance, we mentioned the treatment is stop excessive saline. Why? Because the saline has the chloride. Use balanced crystalloid if needed. Correct the potassium and treat the underlying cause. And that's it, guys. Very long lecture, unfortunately. There's a lot of you to understand. However, we did our best to make it as easy as much as we can. If you have any question, go to the community and put the question. Mustafa is all understanding. I don't think you need here, community. And for Mariam, who joined today, Mariam, the video I put in the Telegram group I tagged you in on, please go and watch it because it will tell you how to use the platform. This is very important. Okay, Mariam? Yes, watch that video. I put it on the Telegram group, and here, let me just show you. So this one, not this one, because you won't be able to use the app unless you watch this video. So I tagged you here, and I said watch this video. This video very important. Okay. If you have any question, drop it in the community, guys. I don't like. I won't be able to take question. That's such a long lecture. Okay. Any question, drop it here. Mustafa, thumbs up. You are interacting. You are putting notes here. Mustafa Ahmed Ibrahim, I like what you're doing. That's fantastic. Unfortunately, no, the side menu isn't the same as the question. Did you figure it out, Ahmed? How to solve the thingy? How to filter the question? Ahmed Ibrahim is not here. If anyone knows, please answer Ahmed here. He put a good question. He said he doesn't know how to. Does anyone know how to filter EMRCS question? Mustafa, I want you to search a YouTube video and put it for us here, please. Put the link of the video here for us. Okay? Put the link of the video here for us.
Inshallah.
Yes. Okay. Interact with each other, with each other, guys. Give those just for give them like give likes, answer questions, download this image, ask any question here. Okay. We have another lecture tomorrow. Just no. I mean like tomorrow we don't have any session. We will meet the other day. Okay. Yalla. Assalamu alaikum.